Good morning, everyone, and welcome, or I guess good afternoon, very recently afternoon. We'll let everybody hop in. We'll give them just a moment, and then we will go ahead and get started. I'm so happy to see all of you back for our third session. And I think I'll give you all just a few more moments to join. Welcome back if you were with us for the past couple of weeks, and welcome. And I hope that you'll take the opportunity after all of the sessions to go back and watch the sessions that you didn't attend. If you are joining us for the first time, we'll make those available by video. So I'm going to go ahead and get started. Welcome. As I said, this is our substance use and pregnancy webinar series. This is session 3 about assessments. Our first session was the medical model of substance use disorders. The second session was about screening. And so if you missed either of those, they'll be available in a recorded fashion. There are 3 of us presenting today. Dion, who was here the last couple of weeks, is away this week and will be back next week. We have Essence Hairston, who runs the UNC Horizons outpatient services at Wake and is also the master of all things related to helping folks in the criminal legal system navigate perinatal substance use disorders. Also Elizabeth Johnson, who's the phenomenal provider at UNC Horizons. And then I am Andrea Knittel. I'm a general OBGYN and also provide care at the North Carolina Correctional Institution for Women. And I'm happy to welcome all of you to our training. We have a couple of disclosure and accreditation statements. There is CME that is offered for this event. You can claim up to 0.5 Category 1 credits for this 30-minute session. If you attend all 4, you can absolutely claim 2 full hours of CME. And there will be instructions in your email at the conclusion. You do only need to complete the evaluation once, so you can wait until the end of the sessions that you're planning to attend to complete the evaluation and claim your CME for all 4 sessions. We do not have any financial disclosures. And so with that, we can go ahead and get started. So for those of you who attended the other sessions, you know us by now. We are a collaboration between UNC Horizons and our research program, which is called Justice Core. And we provide perinatal substance use disorder treatment services, as well as training and technical assistance, which we'll talk more about later. Today, we're going to talk initially about assessing withdrawal for folks who are in the jail. We're going to talk about triage in terms of who goes where and what needs to happen when folks are experiencing withdrawal. We'll talk a little bit about what clinical assessment entails, the levels of care, and when transfer is necessary. And then we'll also talk about how Justice Core services might be helpful for you as you're thinking about making referrals or requesting training or technical assistance for your facility. So I am going to hand it off to Essence to get us started.
Awesome. Thank you, Andrea. So you may be asking yourself, what do you mean by assessment? What is assessment? And so when we're thinking about assessing for withdrawal, we're basically stating be mindful, be vigilant, be aware of signs, symptoms, and or behaviors. So there's a variety of factors or variety of behaviors that you should be aware of. So examples could include agitation. So agitation meaning like extreme irritability or being annoyed, appearing severely depressed or withdrawn, dilated pupils, incoherent speech, or like sluggish speech. So someone who may be unable to speak clearly or in like a linear fashion, increased anxiety or panic. So anxiety can look in the forms of excessive worrying, sweat or someone sweating, heart palpitations, Examples can also include paranoia or substance-induced psychosis. So individuals may report or endorse seeing, hearing, or responding to people who are not present. Also, someone who are experiencing some withdrawal may seem unaware of who they are and also out of touch with reality. Also, seizures, talking about harming themselves or others, diarrhea, tremors, as well as having vital signs outside of the normal range, as well as vomiting. So it's important to note that as you notice those symptoms, they look very similar to some pregnancy-related symptoms, right? But it's important to note that not everything is related to pregnancy, right? So we never want to assume that those most common pregnancy-related symptoms, such as nausea, headache, or anxiety, or insomnia are due to the pregnancy. And we also want to be mindful of dehydration, especially dehydration in terms of withdrawals. And those symptoms can also lead to lightheadedness, fainting, and/or contractions, as well as wanting to refer someone for immediate clinical evaluation that could so we can know if those symptoms are pregnancy related or withdrawal related, or actually a combination of both. So alcohol is actually a unique substance. So when we're assessing for alcohol, we want to think of alcohol as what we call like a downer or depressant that's very similar to like the sedatives, hypnotics, or analytics. My colleague would talk about that next slide. So those benzos or Valiums. But alcohol, what makes it unique is that the withdrawals can be it's actually fatal, which is very different from opioids. Opioids are fatal in terms of intoxication. So is the injection when someone is more likely to overdose. Alcohol is the withdrawal phase. So it's after maybe hours of someone consuming alcohol, because alcohol has this way of slowing the body down. So it's called a depressant or downer because it actually slowly calms the body. And so when we're assessing withdrawal for alcohol, we want to ask certain questions related to how many drinks have they consumed over a week. If you're working in a jail, another way is to ask how many drinks have been consumed in the last 2 hours. So if we're thinking about weeks, think of that as more so of ongoing chronic alcohol use. But if you need to know right then and there what this person consumed on that day, if they are currently booked in your detention center, you can simply ask how much have they used or consumed in the last 2 hours. So that is also assessing for binge alcohol use. We also want to assess for alcohol use among pregnancy. So I'm asking them, have you consumed alcohol at any time while you're pregnant or even before you were pregnant or you found out that you were pregnant? And other signs or symptoms to be mindful of is self-reported risk for alcohol withdrawal or alcohol use. For alcohol use specifically, oftentimes people will report a history of blackouts or loss of consciousness. Severe alcohol withdrawals will include seizures, tremors, and shakes. Anytime that you see things like that, it's always important to refer to a clinic or medical provider so they can be physically reviewed, as well as report, again, recent alcohol use, but less than requires immediate assessment and no history of complicated withdrawal. So again, when we're thinking about alcohol, we want to keep in mind that alcohol is a depressant. So if someone consumes alcohol, it's actually going to slow the body down. They may be in this like slump or slouch space. But because alcohol is a depressant, it's really important for individuals to be clinically evaluated so we know that they're actually physically safe because of the withdrawal from alcohol.
Awesome. And there is just a question in the chat about the level of alcohol intoxication that can lead to fatal withdrawal. And I think, as Essence pointed out and on the slides, if somebody is drinking more than 6 drinks a day and they are a female identified person, more than 4 days a week, that is certainly a red flag. But it really is that chronic use where the body just gets used to having a certain level of depressant, and then when that depressant goes away, everything ramps up, and that is what can be so dangerous.
Absolutely. I'll also add another way you can assess for withdrawal complications for alcohol is asking, do you ever have to use or drink alcohol or beer to function throughout the day or to avoid having those vomiting, seizures, or shakes? So if someone answers yes to that, that is indicative of stop everything that you're doing and contact your local medical provider.
Thank you, Essence. So I will pick this up in essence, as she mentioned. So the two main substances that we get very, very concerned about when we're thinking about withdrawal, we worry about all of them, but the two that we really worry about as far as having really significant potential complications are alcohol, as Essence mentioned, and then also sedatives, and in particular, when you're thinking of benzodiazepines like Xanax, Valium, clonazepam, those types of medications, but can also include barbiturates, and there are some other drugs out there that are also classified here. But as Essence and Andrea's both so beautifully explained, these all sort of are suppressants to the system. And if you have someone who's using chronically, and I would like to sort of mention that particularly with incarceration, this could be someone who is misusing medication. Maybe they're getting it illicitly, but this also would apply to someone who is being prescribed daily benzodiazepines, and that happens quite a bit. I see it all the time in the practice where I am. This can really be something you have to be very careful about. And I also want to just sort of highlight, when you're thinking about immediate assessment, trust your eyeballs, trust what's in front of you. If someone looks unwell, you need to do a little bit of exploration and not just sort of say, well, they need to shake it off or sleep it off or what have you. It's something to really be thinking about. So I think seizures is the number one thing that we worry about, and withdrawal with both sedatives as well as alcohol. That is sort of the number one killer of people, is that they will have a seizure, and then complications of the seizure activity can actually be fatal. And so one of the things to be thinking about with benzodiazepines in particular, whether someone's prescribed or whether they're taking them illicitly, is looking at chronic use again. That can be really complicated, and it's not something you can stop immediately. And so asking patients what they've been using, asking inmates, like, what have you been taking? A lot of people will self-report, and then asking what has happened to them in the past. A lot of people will say to you, when I stopped taking, I had a prescription for Xanax, for example, and when I stopped taking my Xanax, I had a seizure. That is something that should be a red flag to you and make you lean towards getting this person evaluated and getting symptoms managed in a way that's going to be better for them. Next slide. Okay. So we talked in general about the dangers of these two substances in the general population. That's even just more amplified when you add pregnancy on top of them. So generally, if someone's withdrawing from alcohol or from sedatives during pregnancy, we need to be thinking about a higher level of care. You just think about the impact if you have a seizure, the elevated risk of someone dying if they're pregnant, just, all of the sort of anatomical changes that can happen during pregnancy, and all of those things can just make this an even more deadly thing to be dealing with. So getting people to care and to understand that having people just stop, let's say they survive their withdrawal, and they are not getting any kind of treatment, then of course, this is associated with high rates of return to use. That makes complete sense, because once people are released, then they're going to go right back to where they can start feeling better again, from the sense of not having those with protracted withdrawal symptoms. And it's real important that we are coming towards all of the people that we're taking care of with a very non-judgmental approach. If you are open and willing to listen, people will tell you more. It's always interesting to me when people ask about, oh, what kind of specialized training do I need to be able to work with people with substance use disorders? And usually my first answer is, well, there are some things that you can learn how to do, but the first thing you need to do is just be kind and listen. Because patients really will tell you what's going on if they feel safe enough to do that. And for pregnant people, it's really important, because we know we have two patients. So withdrawal symptoms not only are dangerous for the person sitting in front of you, they're also dangerous potentially for the fetus. And alcohol use, we know during pregnancy, it can result in a known syndrome, the fetal alcohol spectrum disorder, or FASD. That is a known entity. And we know that can happen. And then we also know that benzodiazepines, neonates will often go through withdrawal symptoms, and it's a little bit more protracted than when you think about opiates. Opiates tend to show up in the first 24 to 48 hours, whereas benzodiazepines have a sort of a delayed onset of withdrawal. So sometimes if someone's going in to deliver, the baby may actually start getting in trouble once that person's been discharged home. Next slide. When thinking specifically about stimulants, so cocaine, methamphetamine, again, sort of the common theme in thinking about triaging all of these people is, if to your eyes this person seems unwell, you really need to be thinking about doing a little bit more. And it's also real important to remember that with cocaine, methamphetamine, other stimulants, even if people believe that they're buying, medication like Adderall, pretty much that fentanyl contamination is ubiquitous throughout the illicit supply. You just have to assume that someone is consuming fentanyl knowingly or unknowingly, even when you're looking at stimulants. So that's something that you need to be looking at as well. So you may be thinking, oh, this person has been using cocaine, I'm going to be looking for that as far as assessment, and then things look a little bit different, because it may actually over time look more like opioid withdrawal. So it's important to kind of file that away and remember that. So with opioids, we actually have a few more tools. I mean, we have medications that we can help manage the other substances, just the actual symptoms of withdrawal, which we also do for opioids. But then we also have other tangible things that we are able to do for people, and particularly pregnant people. So when you're thinking about someone not looking very well, maybe they are some of the symptoms that Essence mentioned in that very first slide. Maybe they've got a runny nose, maybe they've got diarrhea, they're saying they're achy. There is a standardized tool, the Clinical Opioid Withdrawal Scale, or the COWS. That is a tool that goes through and looks at all of these different sort of domains and how someone might be feeling. If you look at them, a lot of them, some of them are objective, like I can see whether someone is sweating. I can tell if someone's pulse is elevated. Maybe not be able to really judge restlessness, can definitely judge people size, but some of them get to be a little bit more subjective, and that's okay. Believe the person sitting in front of you if they're saying that they just hurt all over. And so this is one of the few tools that we can actually have at our disposal to be able to say, okay, I'm trying to quantify how much withdrawal this person is actually in. And so if you start to see scores go up, particularly like getting up into the realm of 11, 12, 13, that person is in significant withdrawal and really feeling bad. If that person is also pregnant, we really need to be paying attention to that, because withdrawal can be deadly for babies. If the pregnant person is withdrawing, that's potentially a big risk for the baby. So this person really needs to be assessed and taken care of. Next slide. So again, we know that in this withdrawal syndrome in pregnancy can be dangerous, but the really great news is that there are medications that can make this much more manageable, make people feel better, and help them to engage in other types of treatment. And we also we know that withdrawal without treatment with medications and other behavioral health interventions, particularly in pregnancy, is associated with high rates of return to use, overdose, and death. So this is potentially deadly complications for people. But with medications, so the gold standards, we have two choices with lots of research behind them: buprenorphine, which trade names are Suboxone in combination, so it's buprenorphine plus naloxone, or the mono product, which is known as Subutex, and then methadone. So both of those are sort of gold standard treatments. And there is currently a lot of research going on in the United States, looking at the safety and efficacy of naltrexone, which is a different class of medication, but another option for opioid use disorder in pregnancy. Sorry. So truly trying to get into thinking about assessment. So we need to be thinking about what is the risk level. So what is their current use? What do they look like? Like what is in front of you? What is in front of you? What if you ask questions? What if the patient told you, or the inmate has told you? What are you seeing? Have they told you that they have had really severe withdrawal in the past? Thinking about any sort of comorbidities, because of course, if you think about, while opioid withdrawal for most people is not fatal, if you have someone who medically is very fragile, of course, putting the additional stress on a system that's already not doing well can really have more significant negative outcomes. Thinking about on-site management, it's great if you can have substance-specific clinical orders. I know those are in place in a lot of the jails and prisons across the state, but really having very specific protocols to be able to follow, and being able to offer medications and monitoring. And then critically important is just to be paying attention and being supportive so that people can have access to hydration, nutrition, and the ability to get some rest.
Thank you. I'm going to talk just a little bit about complicated withdrawal, and really the expert recommendation. So that is from the National Commission on Correctional Healthcare. That's from the Substance Abuse and Mental Health Services Administration. Complicated withdrawal really should not be managed on site at a jail unless there are pretty comprehensive nursing, medical, and psychiatric resources immediately available, meaning on site, not at home or coming in the morning. And so we really need to think about transferring to a higher level of care, and that is often to a hospital, to an emergency department. If we're concerned about overdose or severe sedation, if we're worried about severe symptoms from the withdrawal or exacerbating that existing medical or psychiatric condition, for folks who have substantial mental health issues coming in, withdrawal may also be something that triggers things like suicidality and other sort of self-harm concerns, and that definitely is not a situation that anybody wants to be managing in the jail. Certainly anybody with unstable vital signs or with those complicated symptoms that Essence and Elizabeth talked about in terms of seizures and delirium and hallucinations. If we know that they are experiencing alcohol, sedative, or barbiturate withdrawal, really, I would say it is extremely rare that that is a safe thing to have happening in a jail. And in pregnancy, there are maybe some very rare circumstances where experiencing some amount of withdrawal in a jail feels safe. But I think that for most providers, and certainly for most clients, it does not. There are just not enough resources available in a facility to manage all of those things. And so we're talking about, transferring out. And next week, we're going to talk a lot more about treatment. And we're going to talk about, in particular, treatment for opioid use disorder and all of those sort of resources. But one of the things that we can provide through Justice Core is also help with assessments. And part of what we have all, I think, concluded as we've worked with jails and done a lot of the research and preparation for these slides is that, if there aren't resources available for comprehensive clinical assessments, there are almost never resources available for behavioral health assessments, meaning figuring out, it may be that you see somebody in your jail who you have seen withdrawing, every so often in your jail for years, right? We know that this is a chronic disease that doesn't get better without treatment. And so you may see somebody where deep in your heart that they have a need for treatment for this, that is beyond just detox and stabilization. So we'll talk about a lot of that next week. But if you have identified somebody who is in withdrawal in your facility, whether you feel like they need a higher level of care sort of in that moment to manage their withdrawal, or if you recognize that, this is a person with a substance use disorder, they are going to benefit so tremendously from referral for substance use disorder treatment that I would really encourage you to consider referring all of those folks to us. So as a group, we provide training like we're doing now. We also provide technical assistance. So if you contact us about referring a client, there will be some things that we do in terms of direct service where we will work with that client, work with your colleagues and your staff to identify and, as I mentioned before, really implement alternatives to incarceration, meaning often, the folks outside the jail who aren't having to manage this person every day really hear when folks in the jail say, what, we can't do this. This is not a safe place for this person to be. And we can help facilitate transfer to a residential treatment program or to another kind of supportive recovery environment where someone will be able to make that progress on treating their substance use disorder. So please do contact us. I'm going to just put our little acknowledgements. We've got everybody on the team as well as our funding here. And then I'm going to put our contact information up. So if you would like to request training or technical assistance, or if you need help with a particular client, please feel free to call our number. We can help connect you with local resources to provide we can help identify medical assessment if that is what you need, although I would say that most jails have some pathway to get that immediate clinical assessment done. But certainly the behavioral health assessments, we can help connect you with local folks to do that, as well as provide some of those services directly. So this is obviously a really sort of rich and complicated topic, but I would love to just take a few questions before we wrap up. If folks have got questions, you can feel free to put them into the Q&A. All right. And then I think I do not see any questions right now. And so I will just ask Essence one question, which is if you could just share, I think one more time briefly, when somebody calls you and says, you know what, I have this client who, she wasn't pregnant last time she was here, but I know that, she definitely has a problem and needs treatment. What happens when somebody calls you?
Yes, that's a good question. So the first thing that we do is that we gather a ton of information, specifically related to their mental health or their symptoms. So even if someone cannot articulate any type of diagnosis, oftentimes people can report how they're feeling. And their emotions, their medical history, pregnancy status, as well as their substance use history, in their environment prior to incarceration. So it's what I call like a structured interview, where we gather a ton of information that then allows us to refer individuals to the appropriate level of care. And so once we get that information, we then coordinate with our program. So Horizons has a residential program in Chapel Hill, but we also coordinate with all of the pregnant parenting women and people programs throughout the state of North Carolina. So once we get that call and we get that assessment, we are actively pursuing treatment options for that individual, and working alongside the jails as well. So we typically get calls, but if you're like, hey, I need you to come to a jail, we can do the same thing at a jail. So we will go to jails, pre-trials. Anything that we'll do anything that makes the most sense for that particular jail, and recognizing that not all jails may even have a fax machine, or so we will do whatever we can do to make sure we get that information from the individual and get that person to the appropriate placement for them.
Awesome. Thank you so much, Essence. We'll wrap it up. Let all of you finish up your lunches and, take whatever break you need before you're back to your work day. And we look forward to seeing all of you next week for our final session focused on treatment for substance use disorders in pregnancy. Thank you all so much for attending, and we will see you next week.